Welcome to today's Friday Chalk Talk. Today we are lucky to have Dr. Arun Ghoshal, a palliative care physician currently practicing in Manipal, a small university town in southern India. He has experience working with patients suffering from both cancer and non-cancer conditions and has engaged with numerous healthcare professionals on an online educational platform to discuss palliative care for liver disease with participants from various regions of India. He has learned amazing things about the diversity of practices from these participants. A fun fact, throughout his career, he has worked in various locations across India. In school, he learned both Hindi and English. And since India is a vast country with diverse regional cultures and languages, he initially learned 2 languages and has found himself learning a 3rd for this new area that he works in. So thank you, Dr. Ghoshal, and look forward to your talk for us on palliative care for patients with liver disease.
Okay, thank you for that kind of introduction. We'll do the slides first. Like there are 22 slides. We'll try to do it quickly and then we'll get into the discussion. Okay, so I'll start. So the first slide, as you can see, is the diagram of the liver and some of the anatomical structures that are kind of surrounded the liver. So I'll try to talk about everything in brief, so don't worry about that. About end-stage liver disease, a bit of cirrhosis, the need for palliative care, the disease trajectory, the models, and complications that can happen. A bit about the transplant, because that's a question that patients or their caregivers always ask. Why not go for transplant and just get out of this phase? And also a bit of updates that have come up in this field. All right. So, very common to see this, the chat question. All right. I won't be able to see the chat when I'm presenting, so I'll get back to it later.
Yeah, okay. When we're done, I'll help guide some of the questions for that.
Okay, yeah, that'll be great. Thank you. So this is a simple kind of pictorial diagram of what happens when the liver disease kind of gets to an advanced stage. Like there is ascites, and there are some other changes that happens in the body. So basically the liver structure gets distorted, architecture, and if the cirrhosis is kind of well controlled, like the patient can still live with the cirrhosis for quite a bit of time, like almost like around 6 to 12 years. But there can be complications. We call it as decompensated or not a well-controlled cirrhosis. Then the prognosis is pretty bad. Like it comes down to almost like 2 years. So what complications can happen with someone who has a liver disease? You can say advanced or end-stage liver disease. There can be hemorrhage from the varices, accumulation of fluid in the abdomen, also known as ascites, then infection in the peritoneum, and sometimes there can be a cancer of the liver. And as you know, the organs are all connected to each other. There can be involvement of the kidney and lungs as well if the liver is not functioning well. We call it hepatorenal or hepatopulmonary syndrome. Right. Now we'll try to get into the area of decompensated liver disease because it's mostly relevant to palliative care. We see end-stage liver disease. That one is unfortunately generally irreversible. For some cases, we'll come to that in a bit, like liver transplantation can be an option, but there are some issues about that. We'll talk about it. Mostly, many cases are not for transplantation because areas where I practice, there are social factors, mostly socioeconomic factors, and then there's a huge long waiting list, and sometimes the clinical scenario might not be conducive for a transplant. But in India, the main problem that I see mostly is waiting list and also finances. It's impossible for them to kind of go for transplant because mostly it's out-of-pocket expenditure. Okay, so throughout the presentation, I've kind of copied and pasted the relevant literature in the slide so that if you want to read a bit more about the issues, you can refer to those literatures. So when we talk about liver disease, people, patients and their caregivers do ask us, like, What do you think is the prognosis like? And so to kind of have a conversation with the family, I think we need to understand the natural history of the disease and some of the tools that we have, which kind of help us to understand the prognosis or kind of the way you want to direct your conversation for that patient will be these criteria. So one of them quite well known is the Child-Hook classification. The other one is known as MELD score, stands for Model for End-Stage Liver Disease score. And if there are complications like we discussed before, like with lung involvement or kidney involvement, some bleeding, etc., then of course the prognosis is poor. So this is the Child-Hook classification. I don't want to really describe this because it's like a table and also available in apps, I think, in MedCal. So it's easy to kind of put the scores and get a score. But the important thing to understand here is that when you do the scoring, it also is about prognostication. So if you see that, so depending on the class A, B, or C, when you add up the scores, it will give you the class. So if you go to class C, the prognosis is pretty bad. So it's around 35 to kind of 45% for 2-year or 1-year survival. It's pretty bad. So the same thing is a different bit of criteria for MELD score. Also, it's available as an app, I think, and can be easily done. But it also kind of gives some idea about prognosis. So this is something that if you deal with this kind of patients with liver disease and their families, this thing comes up mostly all the time. Like they will, of course, ask us, like, please save my patient. And they will say, of course, that they're willing to pay, but why don't we go for liver transplant? So how will we answer that question? So a lot of research has been done in this area. Like, is it like palliative care? Is it like a yes or no answer? Like, well, transplant is possible, so you don't need any palliative care. And on the other hand, when transplant is not possible, you say that, okay, the only option for you is palliative care. Is it like that? Or can there be another model where you kind of, the transplant is possible, but still palliative care can be kind of provided to those patients for symptom management. So a lot of research has been done in this area, and one of the papers that has looked into this area is the one which is cited here. So again, when we talk to patients about this, the most important thing, again, we should understand is that what are the contraindications for liver transplant? So standard contraindications are that if there is another disease where surgery is very risky, like a cardiopulmonary disease, then no. Then there is a cancer where it's outside the liver, like a metastatic cancer, then no. Then if they are not able to adhere with medical care post-transplant, which can be expensive, if they're paying out of pocket and they are not able to kind of continue with that care, then there is no point. And of course, if there is lack of adequate social support, then yes, there is a very low chance of surviving the transplant. So the other things that mostly the doctors who are treating these patients, they kind of refer patients for consults for palliative care. And then if we give the patients Tylenol, simple Tylenol, then most of the times I see they have stopped the Tylenol and they have given other medications for pain management. So what's the big deal about Tylenol? Is it like you cannot give absolutely contraindicated in liver disease, or if there is a safe dosage that we can use for liver disease? So that's the main thing. So I think that if the liver disease is kind of decompensated, we can use some safe dose of Tylenol. Generally, we use up to one or two grams per day in divided doses. We don't exceed that. And some other symptoms that are common in ESLD, as we discussed before, like ascites and other things. And what else can be offered? We'll talk a bit more about it. So what are the needs in general for these patients? In liver disease are pain, tiredness, muscle cramps, dyspnea, as you must have seen in your practice or in your experience, and some psychological symptoms. Then there's a big role for advanced care planning, end-of-life care, pre-transplant and also post-transplant. So now the next few slides are about details for managing various symptoms. I don't think we have the time today to kind of go in details to those slides. So I kind of skip, but we can discuss when we kind of open the forum for discussion. And we can come back to this if you have any specific questions. So ascites, like all of these slides are medical management and non-medical management. Then biliary drainage, if there is a biliary obstruction, what to do about that. Then hepatic encephalopathy, a very poor prognostic factor. Then what are the areas where we can try to avoid hepatic encephalopathy? And if there is encephalopathy, then what to do, like provide hydration, etc., provide lactulose, keep the bowels clear, because it's mostly due to ammonia production in the body through the gut. Then pain management, that was what I was telling before. So Tylenol can be given. Morphine, the problem is that some of the medications are metabolized in the liver. So if there is a medication which can bypass the liver for metabolism, it's better to use that, because we don't know if the other medication will be metabolized in the liver properly or not. So fentanyl can be used, and pregabalin can be used for neuropathic. So, but the practice points are to use the lowest effective dose. Methadone can be used as for pain management. Tramadol and NSAIDs generally should not be used, because tramadol is a prodrug, and NSAIDs can cause more kidney damage and bleeding. Then there's about varicose hemorrhage, how to kind of control that. I'm not discussing in details. Then itching, it's a very common symptom, a very difficult symptom to treat. So some of the pharmacological agents are mentioned here, and some people have tried using opioid antagonists like naltrexone. Muscle cramps, another difficult symptom, not much evidence to treat that. So, but few of the studies have talked about branched amino acids, some supplementations of vitamins, etc. So in summary, these patients have definitely PC needs. Symptom management depends on the underlying condition of the liver and the kidneys. There is a potential benefit from concurrent disease-directed treatment for liver disease, as well as involving palliative care in the co-management for these patients. That was all. Thank you. I think we can open up for discussion. If there is any particular question, I can revert back to the slides. Thanks.
Yeah, I think we do have one question. I guess we'll start with this one. In palliative care, we break bad news, but how do you approach that if someone could otherwise be a good liver transplant candidate, but wouldn't be able to afford to get a transplant?
If there is time, this one, in PC, we break bad news. How do you approach breaking bad news? And the reason is that they can't afford a transplant, even if they would be a good candidate. Yeah, it's a very difficult thing, you know. Like, there are a few things which are within our control and few things which aren't. I mean, we can't do anything about it. So definitely we try to get, I'm talking about my setting here. Every healthcare system is different, right? So here we try to get the involvement from a social worker, because sometimes there are schemes that as a doctor I might not be aware, but they might know if there's a alternate financing mechanism which can be kind of activated for that particular patient. We try that. But if there is nothing, then it's really a difficult kind of area to kind of navigate. We talk to the family, and then we try to understand what their preferences are. We try to explain to them the situation, and then we go from there. There is no particular formula for this. It's a very difficult situation.
Yeah. We end up in a similar situation if there are people that don't have insurance. So we try to get them support if we can, but unfortunately some cannot. And then we just end up, honestly, this isn't going to be an option. So how do we help you live with your liver disease is kind of how we approach that. So then kind of off of that, how do you work with patients and families and help talk about the unpredictability of liver disease? It's the biggest thing I hear is, how could this happen so fast? That kind of thing.
Yeah, that's one thing. So I think the thing that they're mostly worried is about support. And so they meet multiple people during this journey, not only a palliative care doctor, but sometimes they go to the ED, the emergency. Sometimes they go to the internal medicine. Sometimes they see someone else. So the thing is that, are we all talking the same language? I think that's the main challenge. Like we might counsel them in a different way. We do all the groundwork, then they go to the ER, they get seen by a resident, someone who is new in the ER, they might not have that much idea about palliative care. And in many hospitals, it's not like we don't have Epic. So it's not like that, that you open the chart and everything flashes up on your screen. So it's there in paper charts. So sometimes the patients might carry those paper charts, sometimes they might not when they're rushing to the ER. You see, if they call us before they come to the ER, like they inform us that, hey, we are coming to the ER. Can one of you guys come and see the patient when the patient is in the ER? Then it's fine. Then we go there and we try to get the groundwork done that this patient is seen by palliative care. This is what the history is. And so don't do something like which is totally something that the patient or the family doesn't want, like away from their goals of care. It's easier. But if not, then it's a challenge. How do we do that? So under those circumstances, is sometimes you have to do the work again, like talk to them, talk to the other doctors that this is what we have achieved. So please counsel along these lines. Don't do something which is totally different. So that's the thing. Sorry, what the question was?
It's just how do you approach those conversations of unpredictability? But I think you started, it's just support and ongoing conversations mostly.
Ongoing conversations, yeah. So if we have a common language in the medical fraternity, then that's a very positive thing for the patient and the family. They hear a common tune, a common language. So there will be unpredictability, and we can't really give them an idea that this is what is going to happen. We don't know that. No one knows that. It's about support. If they're well supported, then I think that works as an added layer of support and helps to curtail some of those issues around unpredictability. So I think the main challenge that we face here is talking the same language. And then if we are able to kind of satisfy that, able to achieve that, then it's easier for the patient to kind of navigate this unpredictable journey.
Yeah. I think that's something that's universal. We struggle with the same thing. So a question, can you tell us about your journey of how you decided to practice palliative care and how did you get here?
Yeah, sure. Thank you for the question. I studied medicine in kind of a rural college in a rural area of the country where there is no palliative care. So when I was working in medicine, I used to see people coming to the outpatient clinic, say heart failure, whatever, liver disease, and suddenly one day you will see that they stop coming. So what happened to them? Then sometimes we call them up and ask that, hey guys, you're not coming to the clinic. What happened? What happened to you? Why are you not coming? Did you find a different doctor or what happened? So basically they don't come to the clinic because they aren't able to come. They're so sick, they are at home. And there is no alternate way of kind of caring for those people. There's a huge gap. So I thought that maybe I should explore this area because this is something that there is a huge need, but no one clearly is working in this area. So I got hold of a few other people. I don't know whether you know, there's a famous physician in India. His name is Dr. Ghoshal. He is from the southern part of the country. By training, he's an anesthesiologist, but he has been working in palliative care for many, many years. So I kind of emailed him that I'm like a fresh graduate. Do you think I should take up this branch? And do you think I'll make any money? Like we need to survive, right? If I work in palliative care. He said, yeah, sure, you can take it and don't worry about that. That can be taken care of. Because in India, the payment system is a bit different. Sometimes it's fee for service, sometimes it's not. It's kind of different. So my parents are very worried that what are you trying to do? That's why I had asked him all these questions. Then I think my dad also emailed him, but this guy is trying to go in this area. Do you think it's a good idea? So I think he was successful in convincing us, and that's how I got into this.
Yeah, that's definitely different than how ours works for sure. I guess, how did you kind of get into liver disease, and did you notice is it more accepted by your hepatologists and transplant surgeons, or is it something you've had to work through barriers to get into?
No, the liver disease thing happened in a different way. So I did a fellowship from Princess Margaret in Toronto. And then I think I used to work in Toronto General, just across the street. So there we saw a lot of patients with liver disease. And actually, my interest in that area came from there. In India, we hardly get to kind of see patients with liver disease before then I came back to India. I mean, in the middle, I was there. So then I didn't see much patients. We did see patients, but very few, maybe in internal medicine. But when I was in UHN at that time, I saw a lot of patients with liver disease because they have a good program there where it's quite integrated with the liver disease program. So they do see patients with transplant, without transplant, and everything. So I got interested in that over there.
So pretty open to you seeing people even if they're on the transplant list.
Over here, I haven't seen people who are getting transplant.
Okay.
It's a bit unfortunate. So no, but when I was in UHN, the transplant system over there is a bit different because being Canada, everything is paid for by the government mostly. So it goes from your taxes. So people have a fair chance of getting a transplant, though there's a huge waiting list. Over there is a bit different, so we get to see patients over there. But here, unfortunately, it's a bit different. So I don't see many people getting transplant, but they have a lot of symptom burden. So yes, we get involved mostly by gastroenterology or internal medicine for patients who have kind of very advanced liver disease.
Yeah, here it's been a work in progress because working with the transplant program and helping them understand that we can help and we wouldn't take transplant. We can do that while they're hoping for transplant, but given the nature of the list here being so big as well, the higher the MELD, the closer to transplant, but the higher risk they are of dying. So kind of helping our hepatology and transplant teams understand the need for palliative care in a very uncertain time when we don't know what's going to happen, back to the unpredictability piece of it. So, yeah. Are there any other questions from anyone there? Otherwise, I'm happy to keep asking some.
Can I ask Jesselyn a question? Would that be okay?
Yeah.
So Jesselyn started in critical care, and then she transformed into doing general palliative care, and then she transformed into being embedded in the liver transplant team. So you've had two transformations, and you've been on here before talking about your initial one from critical care to palliative care. How have you changed again from that second evolution from being general palliative care to being embedded with our liver transplant team?
It
Sorry to
kind of
put you
felt,
on the spot.
oh no, it's fine. It kind of felt like full circle because that's where I started my practice as a nurse and noticed the need for palliative care. And at that point, that was over 10 years ago, and it wasn't brought up, especially not in transplant. So we would recognize the need, but we couldn't involve palliative care. So kind of being able to be that one and build that collaboration just kind of felt like coming home a little bit. So it's just a population that I find very easy to talk to, despite how hard it is. Just because you can speak from the heart after seeing what they go through in the ICU for so long. So I really liked it and felt comfortable kind of doing it right away. And the biggest part was going in easy and establishing some trust so that they would let me stay. But kind of felt smooth. Otherwise.
I'll sneak one more in,
Yeah.
and then maybe we can conclude. All right, Arun. What, not maybe specific to just liver disease, but what are some of the biggest challenges you face in palliative care working in India?
I mean, of course, access to pain medication.
Hmm.
For example, morphine, very simple pain medication. There is a huge issue with that because it's so kind of regulated by the government. People don't want to kind of dispense morphine, and they're very worried about morphine or any opioid, maybe morphine, fentanyl, whatever, apart from cancer hospitals, people are very worried about that because they don't use it much in regular practice. So someone it's a bit different, right, from Western countries. Like over there, the problem is that there is an abundance.
Yeah.
And over here, the problem is that people need it, but it's so tightly controlled that you don't get it. That's the major challenge.
Mm.
And also, socio-culturally is a bit different from the Western concept of autonomy. When I used to just talk to the patient, no, directly, like this is what you're having, what do you think, what your preferences are, stuff like that. Over here, it's not so straightforward. We have to talk to the family, the patient. Many of the times, the patients, of course, they know, but they don't want to kind of discuss very openly about the condition. There is a huge kind of invisible, barrier talking to the patient. The families kind of try to keep the patient away from all kind of medical information. I don't know why. So it's a bit different communication. We have to talk to the family, talk to the patient, try to do family meetings so that they are on the same page. Then someone else takes the decision for the patient. Most of the times, it can be someone else in the family who takes the decision. So the Western concept of autonomy is it's a shared autonomy, I think, here.
Mm.
So autonomy of the family. That's very different from what you will see there.
Small world. We know Dr. Raj. I've had him on before, and so you have a wonderful mentor in him. He's a great guy.
Yes.
All right. Well, then I guess if there are no other questions, I think we can wrap up for today. Thank you so much, Dr. Ghoshal, for spending your evening with us and for talking to us about liver disease.
Thank you very much. You guys have a good day.
Thank you. You too.
Bye.